We are live.
A very warm welcome to iFocus online lecture number 506, the Ophthalmology Clinics exam special. Today we welcome the esteemed Dr. Jyoti Shakrawal to teach us on the grand Viva-Interpretation of images, glaucoma. She completed her MBBS from Savai Mansingh Medical College, Jaipur, did her MS Ophthalmology from RP Center Ophthalmology Sciences, AIIMS, New Delhi, did her senior residency in glaucoma, pediatric ophthalmology, and squint at RP Center for Ophthalmic Sciences at AIIMS, New Delhi. She is currently the Associate Professor at AIIMS, Jodhpur. She was awarded the Young Ophthalmic Teachers of India in the 7th National Assembly of Ophthalmology Teachers of India. She received the Gold Medal from Glaucoma Research Award by Lieutenant Shri Janardhan Prasad at AIIMS. She was awarded the Best Postgraduate Thesis at ARC-AIOC Young Researcher Award, the Best Paper in the 10th International Congress on Glaucoma Surgery and Delhi Ophthalmology Society Conference, Best Poster in the 8th International Congress on Glaucoma Surgery and 75th All India Ophthalmology Conferences. She has 35 index publications in various national and international journals, including 17 original articles, 1 review article, 17 case reports, and letters to editor. She's contributed several chapters in various journals and books with a H index as high as 9, such as Practical Approach to Glaucoma Case-Based Theme Publishers, Video Atlas of Strabismus Surgery by the CBS Publishers. She's also a member of the editorial committee for AIOS Expert Guidelines on Diagnosis and Management of Primary Angle Closure Disease 2018. She's also the invited speaker and has presented several national and international conferences. We're honored to have you here, ma'am. Over to you.
Thank you, Dr. Ashwin, for the very warm introduction. Is my screen visible?
Yes, ma'am.
Okay, thank you. So a very good evening to all. First of all, I would like to thank the entire iFocus team for giving me this opportunity to come on this platform, which is so famous and popular among entire residents, or I must say all ophthalmologists. So today I'll be talking on interpretation of images in glaucoma. I have no financial disclosures. So the outline of my PPT would be static perimetry followed by kinetic perimetry, and in the end we'll discuss on OCT. So what is Humphrey's visual field analyzer? It's a tool used to measure and monitor the visual field function. It is an automated and static perimeter where the fixed points of light are shown at different locations and intensity levels of each point is measured as a threshold. So what is that threshold? It is the light intensity in decibel seen at least 50% of the time at a given location. So I'm coming on the interpretation of the printout. So when a printout of visual field is given to you, you should start with, did the examiner understood the test? Did he perform the test well? So the following parameters we'll be discussing one by one. And secondly, did the patient perform the test well? So under which we'll see the reliability of visual fields. After that, the questions should come into your mind. Is it glaucoma or not? And after seeing it is glaucoma, you should know where it is stable or progressing. So we'll be discussing all these points one by one. So this is the printout of Humphrey's visual field, and generally we classify this printout into 8 zones. So what are these zones? The zone 1, which include the patient information and the strategy. But zone 2 includes the reliability indices. Zone 3 includes that grayscale. Zone 4 is showing us total deviation and total deviation probability plot. Zone 5 includes pattern deviation and pattern deviation probability plot. Zone 6 includes all the global indices, which include VFI, MD, PSD. We are going to discuss them one by one. Zone 7 is glaucoma hemifield test, and in the end, zone 8 consists of these numerical data. So, did the examiner understood the test and enter all the information which is required for the test? This is coming on the top of the printout. That is zone 1. So first of all, date and time should be entered. So you have to check, look for that. And the most important thing, the date of birth of the patient, because the machine itself has age matched normative data. So to compare with the age matched normative data, the age of the patient should be entered correctly. So here you see there is the age of the patient. So you can begin with the printout information with the patient details with the age of the patient. Secondly, pupil diameter should be normal. It should not be neither pyrocarponized nor dilated. The visual acuity of the patient should include entered in the machine. And for the Humphreys visual field, the visual acuity should be or more than or equals to 618, the cutoff we take. And most important thing, the near correction must be given to that patient. Here, the zone 1 also showing us what program strategy we are using. So the stimulus size and the color is documented, the background stimulus and the strategy used for that test. So which test should we order? It should be 30-2, 24-2 or 10-2. So various in 30-2 we see 76 points which are 6 degree apart. So it measures the 30 degree in all directions from the point of fixation. What happens in 24-2? It measures 30 degree nasally, but elsewhere it measures 24 degree from the point of fixation. And to look for a more centrally 10-2, we see 10-2, which includes 10 degree from the point of fixation. It is used for advanced glaucoma or in macular conditions. So what does this -2 means? So first of all, have a look on what -1. So -1 is the points along the vertical and horizontal meridia are checked, but we don't know they are included in which zone, either superior or inferior, because the points are on these meridian. So the -2 picture come. This is the new and improved pattern where the grid of points are checked 6 degree apart. Means they are 3 degree apart from the either meridia. So we can see these points are in this quadrant, these points are in inferior. So this is easy to interpret. So -2 is gives us better interpretation of the points checked. And which strategy? So you have some basic idea about what is threshold strategy and bracketing mechanism. This might be I asked in your Viva. So initially, when the machine starts the test, it checked the first 4 points, cardinal points, which are 9 degree away from the horizontal and vertical meridia. So the test begins from this in all the 4 zones. The test begins from these 4 cardinal locations, which are 9 degree from both the meridians. And then after checking the threshold of these points, we perform the test for the remaining locations. And what is this bracketing mechanism? First, suppose the machine has started to checking the stimulus of sensitivity of this point. So first, the machine will give you, for example, the machine is showing us 30 decibel, then 30 decibel is seen by the patient. Then we are going towards the dim intensity, that is 34 decibel. We are going up in the steps of 4. Then 34 is seen by the patient. Then we are going 38. Okay, the patient is not able to see 38. Then we are coming back to 36 from 38. So the 2 decibel down steps are we are doing. So we stop where the patient see those stimulus. Sita, the updated version is Sita Standard, Sita Fast, where the machine knows itself that this is bound to happen. If the patient has this defect, the adjacent point must have the sensitivity of this much. So the machine knows this is bound to happen in glaucoma. This is impossible. So the machine modify the strategy, modify the machine while doing the test. The machine modify the questions to the patient after seeing their responses during the test. So it is more time efficient and it increases the patient acceptance. So now the examiner has done his part. Now, what did the patient perform the test well? So this information is given here on zone 2 of the printout. So what this information is giving, what reliability indices are there in the zone 2? Fixation losses, false positive, and false negative errors. So what is fixation losses? If the patient sees the stimulus on the blind spot, that is impossible. So the patient has lost the fixation. Fixation losses should not exceed more than 20%. False positive, if the patient is trigger happy, he is pressing the button when there is no stimulus. So that will give you false positive result. False positive should not exceed 20%. False negative, when the user did not press the button, where he or she have pressed the button previously for a dim stimulus. So the false negative also should not exceed beyond 33%. So these are the printouts of a very high false positive patient and a very high false negative. So this high false positive trigger happy patients will give you a pattern which is known as Swiss cheese pattern on this grayscale, and this very high false negative patient will give you a pattern of clover leaf. Why? Because first the machine start the test with these 9 degree away locations in either zones in each of the quadrants. So where there the patient was attentive and pressed, but later on the patient did not press the button while checking the other points. So it is giving you the clover leaf pattern. This numerical zone 8 consists of numerical data, which is giving us the measured light sensitivity in decibel at each particular test location. So we can seeing this is more towards the macula, 32, and we going periphery, 29, 26 decibel, 23. So towards going the periphery, the sensitivity of the points is reducing. And the numerical data is now converted to grayscale. How it is converted and calculated from the points on the numerical data? By dividing the numbers, the raw data into 8 zones, color coded 8 zones. So suppose this is from 1 to 5, 6 to 10 decibel, 11 to 15. So these decibel units are converted into the different shades of gray, which we are plotted here. And as the darkness is increasing, the sensitivity of that location is less. So this grayscale is easy to show to your patient. If to explain to your patient, you can use this. So now the examiner and the patient has performed their test well. Now you have the printout and now you have to see whether it is glaucoma or not. So for that we are going on the other zones, which includes zone 4, which was total deviation and total deviation probability plot. So what is total deviation? It is the deviation of patient result from that of the age-matched normative data. Suppose the patient raw data is showing us 34 and the normal sensitivity there is some of 40. So it is 25 minus 40. So the patient response minus the normal age-matched controls. It is giving you the total deviation. And always pay attention to the symbols in the total deviation probability plot. So what these symbols are giving us information, this is also written on the inferior half of the which printout. So what does it mean? Suppose this is the symbol. So it is showing the probability of having this defect in normal population is less than 5%. As the darkness is increasing of these symbols, the probability of having this much intensity at that sensitivity of that point is less in normative population. Suppose this dark complete black is showing us the probability of having this much sensitivity at this point is less than 0.5% in normal population. So what is the importance of total deviation? It is giving us the idea of the overall visual field loss, but it has a limited value in determining the focal losses. So how do we get these information about these focal losses? The information is given to you on this zone 5, that is pattern deviation and pattern deviation probability plot. So pattern deviation is derived from the total deviation, but after removing for the causes for any generalized depression, maybe cataract, maybe uncorrected refractive error, or maybe if the pupil is so miossed. So all these generalized depression causes are eliminated by the machine itself, and it take out the pattern deviation. But so let's have a look on the numbers. So how it was calculated. So the pattern, and theoretically we say pattern deviation will give you the average of the first 17 points in the total deviation. And how it is calculated? It is calculated by subtracting the seventh best uh, sensitivity value. If we arrange these numbers in the increasing order, so the seventh best depressed value is eliminated from each value. Suppose this here, if we arrange these numbers, the seventh best value is 14. So 14, after removing 14, with this 14, it will become 0, 27 will become 13, 31 will become 17, like this much. But it is not that much easy. The machine is doing this job. So what is the importance of pattern deviation? It is giving us focal defect after adjusting for the overall sinking. Suppose I'm giving you some examples. Suppose there is an exam paper, and uh, the passing marks is 15 or 20. So the examiner give grace marks of 15 to every student. So that is deducted from every student while calculating the performance. But for passing the students, grace marks of 15 is given. So similarly here, a fixed seventh best depressed number is subtracted from the entire value, and we are looking for these focal defect after removing the causes of generalized depression. But always have a look on the fundus, and you have to correlate your finding with the fundus pictures or clinical reports. After covering zone 4 and 5, let's come on the zone 6. That includes glaucoma hemifield test. It is also an important criteria of Anderson, so it has its own importance. So what does glaucoma hemifield test does? It compares the sum of threshold values in the corresponding areas of superior and inferior hemispheres. So 5 superior zones and corresponding 5 inferior zones are analyzed based on the anatomy of retinal nerve fibers, and the results are given as outside normal limit if there is significant difference in any zone which is seen in 1% of the normal population. The result is interpreted as borderline when there is a significant difference which is seen in 3% of the normal population. The result can be general reduction of sensitivity or abnormally high sensitivity when all the points are showing very low or very high sensitivity. And when none of these criteria is met, we label it as the test is within normal limits. Now we have zone 7 below this glaucoma hemifield test. It includes the information from all the point tested and giving us the results in single digits. So it is easy to show to your patient. Let's discuss these one by one. So most important, visual field index. So what is visual field index? The percentage of normal visual field, residual visual field of the patient after adjusting for age matched. It ranges from 0 to 100. So visual field index is derived from pattern deviation, and how it is calculated, a depressed value of each point is calculated by the machine, and then 100 minus that depressed value of each point is calculated, and that is the visual field index of that particular point, and then we make an average of the entire points. But while making an average, the central points are giving more values and eccentric points are giving less weightage. So that's how the machine comes up with a percentage visual field index, the residual visual field of the patient. And the importance of visual field index is also there in assessing the progression while doing guided progression analysis on Humphrey's visual field. The another important parameter is mean deviation. So here we can see as the mean deviation is minus 9.52. How does it calculated? It was calculated by doing a total average of total deviation. So it is the overall depression of the visual field. The more negative the value, the more worse the fields are. So here it is showing minus 9.5 decibel, which is normal in less than 0.5% of the population. Mean deviation also has an important value and under Anderson classification. When you look for Huda-Parrish-Anderson classification, we classify early, moderate, and severe glaucoma if the mean deviation is less than 6, -6, between -6 to -12, or more than -12. So it will give you a gross information about the severity in a glance. The last global indices is pattern standard deviation. So it is the index of degree to which the threshold values differ from each other. It is a difference between a given point and its adjacent point. So here you can see in the raw data, here is 33, 33, 30, 27. It is reducing while going towards the periphery. So this is how we are expecting. But in the superior quadrant, you see here 30 towards the macula and suddenly 0, 0, 9, 19. So this variation between the adjacent point is giving us an indication, alarming indication towards any focal defect here. So by this difference, the pattern standard deviation is calculated, and it is a more specific indicator to look for the any focal defect. Suppose, for example, if there is cataract and glaucoma patient, so the cataract patient have less mean deviation, and the glaucoma patient also have less mean deviation, but the cataract patient must have normal pattern standard deviation. But on the other hand, the glaucoma patient will show you some positive pattern standard deviation. So in this patient, you can see the pattern standard deviation is 15 decibel, which is seen in less than 0.5% of the normal population. It has also an important role in Anderson criteria for defining scotoma. So let's come, what is a scotoma? So these are the points, 3 points criteria for glaucomatous defect in a visual field printout. So a cluster of 3 or more non-edge points which have the sensitivity of less than 0.5% of the population, and one out of which should have the probability of seen in less than 1% of the population. The second would be the pattern standard deviation, which has a value that occurs in less than 5% of the population. And third one is the glaucoma hemifield test should be abnormal. So either one or maybe more should fulfill for defining a scotoma. So after analyzing your printout, you must see your patient, you must correlate your findings, visual field findings with the patient findings. So the structure and function correlation is very important. Just we can't do anything after seeing this printout without seeing the disc. So we have to see the fundus photograph also. So this is these are the supposed example. This is a patient. Fundus is showing us significant cupping, neuroretinal thinning here in the left eye, which is representable on this visual field printout also in the form of superior arcuate. Here you can see the other eye, right eye, is seeing us some focal defect inferiorly, which is giving us some superior nasal defect, beginning of nasal defect, nasal step in the visual field printout. And these results are also can be seen on the OCT printouts. Here you can see in the right eye, you can see inferotemporal thinning. In the left eye, you can see significant thinning in most of the quadrants. But the RNFL defects come early, followed by disc defect, and followed by visual field defects. So the visual field will show you defects when there is almost 35 to 40% loss of the ganglions. Then only these defects are reproducible on the printout. So to summarize, Humphrey's visual field, how to read this printout. If you are given a printout in your exam, and if your examiner asks you, please read this printout, then you have to begin with, this is a single field analysis of a 61-year-old patient by using Central 30-2 see the fast strategy for the right eye with near correction given. The pupil was neither miossed nor pyrocarponized. The visual field is reliable. You can say fixation losses are this much, false positive or negative. You can directly say the visual fields are reliable. Then let the examiner put up the next question for you. How do you say the fields are reliable for you? Then after seeing these reliability indices, you can directly go on these total deviation and pattern deviation plot, which has more value in diagnosing glaucoma or any other defect. So the total deviation plot is probability plot is showing us a superior arcuate, and the pattern deviation is also reproducing the same defect after removing any generalized depression. So it is giving us also a superior arcuate. And then come to global indices. The global indices are abnormal with a VFI of this much, mean deviation of this much, pattern deviation of this much, and simply say the glaucoma hemifield test is outside normal limit. So then the examiner will put up the question, how would you say the it is out, how do you interpret glaucoma hemifield test, or what is this, what is that? But you have to read this much only. Then in the end, you can say Anderson criteria will be met if these defects are reproducible on the consecutive visual fields. Therefore, the given visual field shows a superior arcuate scotoma, which is breaking into periphery, now going in the periphery, suggestive of glaucomatous damage. And in the end, you should say, but the clinical correlation is required for this patient. So that's how you read a printout of Humphrey's visual field. Now, after diagnosing glaucoma, how to see whether this is stable or not. So what is progression? So what is progression? Either it is deepening of the existing defect, enlargement of the defect, existing defect on consecutive fields, or any new defect on the follow-up fields is labeled as progression. How much field you should order? At least 6 visual field in the first 3 years, because this test has a learning curve. So to overcome learning curve, to create a baseline and to assess the rate of progression, you should do at least 6 in 2 years. And in the Humphreys visual field, we have guided progression analysis software to look for the progression. It has both trend-based and event-based analysis, and that is shown in the form of graphs and triangles. I'm showing the printout in the next slide, and the rate of progression in GPA is what? It is visual field index. So this is a printout of GPA. It is giving you 2 baseline examinations of the patient to establish initial visual field status and VFI value of both the baseline examination. Below that, you have the rate of progression that is seen here on the basis of VFI, and then VFI plot, and this is the VFI bar, which is giving you the trend, which is giving you the trend of the patients in consecutive years. And below that, you have the current visual field summary along with the GPA alert. So what is GPA alert? I'm telling you, but for this GPA, you should have at least 5 visual field of the patient and at least 3 years of follow-up. Then only the machine can calculate this. So for GPA alert, it is the event which is happening. So it is shown on the progression analysis map of the GPA printout, a complete triangle. You can have open triangle, half triangle, or a complete triangle. So if the field is or a small open triangle, is a deterioration is expected in less than 5% of the time at a location. That is full triangle, empty triangle, and the half filled triangle is deterioration at the same location in the 2 consecutive fields. And if the deterioration at the same location in 3 consecutive fields, you get a full black triangle. And you have 3 half triangle in one exam, that is possible progression, and GPA alert will give you likely progression if you have 3 full triangle in the exam. So how to read this printout of a GPA? So this is a GPA report of the left eye of patient, name this. The upper 2 fields depict the baseline fields of the patient on showing us the visual field index of this 96%, mean deviation of this, pattern standard deviation of this much. Below that is a VFI plot, which is giving you a steeper slope, showing us a significant progression based on the VFI values. And this is showing us this bar, and this curve is also showing you the 3 to 5 year projection. So what is going to happen if this much trend is going to follow? In near future, in 3 to 5 years, this much loss is going to happen. And the rate of progression is written here. It is -3 plus -0.9 standard deviation percentage per year, calculated from VFI. And below that, you have the current visual summary of the patient, giving you all the indices along with a GPA alert. And this GPA alert is showing you the likely progression. So you have the full triangles 3 in this picture. Quickly, we'll review after the static perimetry, few salient features about the kinetic perimetry. So what is the indications for kinetic perimetry nowadays? We don't have this machine in most of the places. So whenever there is the visual acuity is less, it is less than 618, you can go for kinetic perimetry. If the patient is not able to perform static perimetry, the Humphreys test well, so you can go for kinetic perimetry, or it has a value in neurological diseases nowadays more. So, and you have to look for beyond 30 degree. What is the visual field? So you have to go for this kinetic perimetry. So quickly, this picture of Goldman visual field printout, which is showing you the isopters. What is this blue circle, red circle? This is the isopter, which is formed by joining the sensitivity of each points with a given stimulus. So what is this number? 54E will tell you. The Roman number will tell you the size of the stimulus that is written on the left side of the printout itself. And the Arabic number 1234 will give you the brightness of the target. And again, the finer calibration of the brightness is done by these alphabets. So this is the size and stimulus intensity, size and intensity of your stimulus given target. So that's how the printout. And this printout is showing us, this is the left eye. The left eye, you can see blind spot. This is the left eye Goldman visual field printout of a patient, which is showing us a superior nasal step, which is broken into the periphery. It has gone to form superior arcuate and gone into periphery also. What this printout is, Goldman printout is giving you information, left eye GVF printout of the patient by using target 54E, and it is showing us inferior nasal step and superior arcuate, which is almost gone break into the periphery. As I have already told you, it has a value in neurological testing. So this is a printout where you can see this is the right eye. You can see blind spot on the right side. So the left side is gone for this patient. Here you can't see left side blind spot. So this is left-sided homonymous hemianopia. Then lastly, let's discuss about the OCT. So why it is difficult to diagnose early glaucoma? Because of the variation between the normals in axonal count among the normal population. There is a large overlap. Means suppose I might have this much number with a small disc and normal, and this much 1.2 million with the large disc and might be abnormal. So there is a huge variation in the axonal count. The rate of functional and structure progression can be highly variable among subjects. So we need something to determine the loss before more damage has occurred. Here you can see in this picture, this is a small disc with 0.5 cup, and it is significant here. But these large discs with this much 0.5, 0.6, maybe 0.7 cupping might be normal, and with small disc with a 0.45 cup might be alarming. So we need to diagnose early glaucoma. And all these nerve fibers are converging, all the axons are converging where on the optic nerve head and peripapillary nerve fiber layer. So we need to see this in more detail. And are we really interested in macula in glaucoma patients? Yes, we are interested because glaucoma is manifested by the loss of ganglions. And we know the majority of ganglions are concentrated on this area, which is macula. So, more ganglion cells are there. So, a slight loss of this area will lead to more damage to the patient. So, we need to pick up these defects early. This is a picture, this is a diagrammatic picture, which is showing you the disc, the nerve fiber layer originating from the superior field. These are the pattern arrangement of the nerve fiber layers. So the superiorly, the more vulnerable area is outside the macula. But inferiorly, we can see if there is loss inferiorly, the fibers are going, the arrangement is in such a manner that the more vulnerable area is inside the macula. So although more important in inferior defects here. So before jumping on the RNFL printout, OCT printout, you should always have in your mind about the clinical picture. So how do you look for these subtle fine RNFL defects which might easily get missed on the examination? So this is a patient which is showing us this darker shade RNFL loss here. The RNFL defects are more clearly visualized on a red-free picture. Here you can see this dark color. This is showing us RNFL defect in this area. So you should have idea how to look for these subtle fine defect in early glaucoma, in glaucoma suspects, or maybe the other eye of a patient. Suppose one eye is showing us advanced glaucoma and the other eye might be glaucoma suspect. So you should see something a bit beyond the optic nerve head to look for these RNFL defects. And let's come on the printout information. What this OCT printout is giving you the information. It's giving you patient details are on the top of the printout. Then you have to look for the image quality. The signal strength should be or equal to 8. Then only you should look for that scan. Otherwise, no need to read that scan. You ask for another scan. So image quality should be or equal to more than 8 out of 10. This next is this topographic landmarks and segmentation, which is showing us again the accuracy of the test. This is also a test which is highly dependent on the examiner and the patient itself. Does the examiner focus the disc properly, or the patient is doing this test properly? So that's how that after that only you will get the accurate markings which are on the optic nerve head exactly. Then only you can see the good results. Then we have superior in the superior half of the printout, we have the RNFL thickness map itself, color coded. Then here you have RNFL deviation map, then raw data parameters regarding the RNFL and disc. Then we have this curves for the RNFL and rim. And in the end, look for these sectoral and clock hour examination of the RNFL thickness. So how do you read the printout? If you have given a printout, this is a printout of this is patient, and always look for the signal strength. Then only you proceed with your findings. So superiorly, you have this RNFL thickness map. This color-coded thickness map, the hotter colors are giving you a good thickness value, and this blue is giving you thinner values. And this is the ONH grayscale. It is a grayscale representation of the cup and this neuroretinal rim. The next is this deviation map. This is RNFL deviation map. This is the sum of the reflectivity from each of the A scan, and this is giving you, suppose this red area is giving you the information that there is some deviation from the normal. This is normal, and this is giving you deviation from the age-matched normal population. Then you have the sectoral printouts, quadrantic maps of the RNFL thickness. So you see, we usually the machine grossly, if you have to look at the printout, you can divide into 4 quadrants: superior, inferior, nasal, temporal, and the RNF thickness is written. Average RNF thickness of that quadrant is written, and the normative database deviation from is depicted in the form of colors. So it is also color coded. You can see within normal limits, green, borderline, and outside beyond normal limits, white will give you thicker values. Then you have this parameters of disc and neuroretinal nerve fiber layer. Raw parameters about the RNFL thickness, rim area, disc area, rim volume, cup volume, and then average cup disc ratio. All these things are written on this table. And then the other important thing which we have to look in this printout is any asymmetry between the two, because that is also important. So the asymmetry between the two eyes should also be looked from these parameters. In the in between you have these curves. So this is the temporal superior, nasal inferior, again temporal curve for the rim, neuroretinal rim, and below that you have RNFL thickness. So you can see left eye, right eye, double hump is the normal curve you see in normal patients, which should fall in this green zone. And here you can see it is going, there's dipping here, thinning, again thinning of the rim, and the nerve fiber here is also showing some thinning here. So you have to look for this graph, this curve also in the printout. Don't directly jump on this sectoral maps. Then after sectoral, you have further subdivisions in the form of clockars to look for which clockar is really showing us the thinning. But you have to look for entire. Just don't jump directly on this. Just color of this 4 quadrant. Okay, all this green, green, green. Okay, this patient is normal RNFL. No, the patient might have abnormal curve for neuroretinal rim or maybe nerve fiber layer in the curve. So you have to look for all the things. After this RNFL, the machine will give you the information about the ganglions also. So this is the thickness acquisition map, which is given by the machine. It gives you measurement of the ganglion cell and inner plexiform layer by a 6 into 6 mm cube, and giving us the annulus picture centered on the fovea and giving you this is the magnified view, and this is also again giving us the color coded picture of the thickness of ganglions in the 6 into 6 mm cube. And this again, this is a deviation map. This is giving us the information that this much deviation has occurred. This red is showing us deviation from the normal. So after reading that printout, of course, you have to look to your patient. So the structure should correlate with the function. For example, this is a PCG patient having repeated attacks in the right eye. So it is showing us more cupping, this inferior thinning of the neuroretinal rim, which is reproducible on this printout of Humphrey's visual field in the form of superior arcuate. And here you can see thinning, deviation, and it is also showing us thinning in this quadrant, so inferior, temporal, superior. This graph is also showing us a dip, neuroretinal rim. This is showing us a dip for the right eye. This broad line is showing us right eye, and this is showing us dip here more. And the left eye, which is no attack yet, but it might be PAC, primary angle closure, and the neuroretinal rim is healthy so far. So the machine is giving us normal parameters. And again, another important thing for while reading, another important thing for OCT RNFL is it is able to determine the pre-perimetric glaucoma. So this is a patient which is showing us visual field defects in the right eye, which is corresponding exactly the thinning of the neuroretinal rim here. Superiorly, we can see the right eye and temporally also thinning. So this is giving us a picture of inferior arcuate on the visual field. But the right eye of the patient is not showing much thinning, and the visual field printouts are also not showing any scotoma. But what additional information this OCT printout gives us is in the right eye, you can see, of course, it is showing us thinning. Superiorly, we can see there is superior, the neuroretinal rim is almost gone. So you can see the neuroretinal rim, see the dip. So there's thinning of neuroretinal rim superiorly, and right eye is exactly showing us the result, which is correlating with the visual disc findings and the visual field findings. But what we saw in the left eye, there here also, the left eye, there is a bit thinning of the neuroretinal rim in the inferior temporal quadrant. So this is determining, this is picking up a pre-perimetric glaucoma before the damage has occurred or starts to appear on visual field. So it has important role in determining the pre-perimetric glaucoma. Again, if the another importance of OCT is, suppose this patient comes to you in your OPD, you can see large disc, large cup. The resident might get confused whether it is glaucoma or not because the cup is deep, large 0.5, 0.6, here it is 0.6, it is large, deep, so they might label it as glaucoma suspect or the glaucoma maybe. But when we do RNFL OCT for this patient, this is showing us all the parameters. They see this graph beautifully go in the green zone, no thinning is showing by the OCT. Another important thing which might be asked in your Viva, what is green disease and what is red disease in OCT printout? So what is green disease? The OCT is normal, but the patient has glaucoma. Why? Because the variations in the normative databases, the device calibration, the disc not get centered exactly on the circle, or maybe the patient demographics contribute to this issue. So a subtle structural change may not be trigger abnormal findings here. So this is giving you all green, but the patient has inferior thinning. So you have to look beyond this color-coded image. You have to look on the clinical picture of the patient and stick to your findings to avoid underdiagnosis. And on the other hand, what is red disease? The patient is normal, but the machine is showing you red color, means RNFL thinning. So this is a myopic patient with large disc, large cupping, but it is not showing any visual field effects. When we do a visual field effect, they're absolutely fine, and the OCT parameters are giving us thinning in the temporal, superior temporal, inferior temporal quadrant. But here the patient is myopic, and this large disc in myopic patient will give you false positive. So this you should know. And in the end, what is floor effect in an OCT? The RNFL thickness does not go below 40-50 microns. So there is no use of OCT in advanced glaucoma. So to summarize, OCT is not an essential, but it can help you to diagnose and follow up glaucoma patients if you know when and how to use it, when to read it. When the signal strength is more than 8 or equals to 80, then it is ideal, and then only you should consider it. So spend time on reading the disc or RNFL photographs, correlate your OCT findings with the clinical findings. And you must learn to read artifacts in the OCT, because there are so many artifacts which can give you false positive results. So this is from where you have to read about the visual fields, about the OCT. That's it. Thank you. This is my email ID. If you want to contact for any query, you can come up and tell us.
All right. Thank you, ma'am. That was a comprehensive coverage on imaging in glaucoma.
Thank you.
Yeah.
So, any questions?
Yeah, we have a few
Right.
questions.
Yeah.
Yeah. Begin with, the first question is, how do you differentiate between early glaucomatous changes and physiological optic nerve head cupping on imaging? Are there any, specific criteria to do so?
Per se on imaging, you're saying, first of all, patients. Okay, so you have to look to your patient. You have to look for optic nerve head in the 90D examination. You should look the disc. You should look the RNFL defect. So suppose the patient is normal, physiological cupping is there, so there won't be any RNFL defect. So you can go, after looking on the 90D examination, you can go for imaging. So imaging will give you some quantification. So take a fundus photo, take red-free fundus photographs, then look for those RNFL defects, then go for OCT. So as I have shown you, the physiological cupping won't show you any RNFL thinning, or the patient, these are not patient. So the person won't have any RNFL thinning on the red-free photograph also, or on the RNFL OCT. But on the other hand, the suspect might have some sort of thinning on RNFL. And macular thinning, yes, you can, the ganglionic cell layer analysis on OCT has very important value. It has its own importance. Suppose the glaucoma suspect or the ocular hypertensives might have some amount of loss in the macular region. So this might not picked up on visual field examination. So you can see the ganglion thickness thickness of the ganglion at the macula itself. That has its own value in suspect also.
Okay. And in case if all these are negative, okay, still we have to follow the patients despite the imaging being negative, and we have physiological cupping only. As a PG, it's difficult for us to
Yes, sure.
differentiate between both. So how often should we follow up, or annual screening is more than enough?
Okay. So yeah, so initially, after not only this photographs, the imaging we are doing all the other parameters also. We are saying looking for the intraocular pressure, we are looking for the corneal thickness, and other examination is equally important. So you have to look for IOP, CCT, everything is normal, or you may have some doubt. You can call your patient more frequently for couple of few weeks, and then you can ask the patient to come back maybe yearly. That is sufficient, more than sufficient. But in addition, you have to ask your patient not to, if he feels anything, he had to report. Avoid steroids. That is a very common, because these are glaucoma suspects. So these are higher chances of steroid responders. So you have to add on these what instructions you are giving to your patient, when to come, when not to come. But if you're not coming, you're coming annually, you have to follow these things.
All right.
And also, if they are relatives, any family members is having glaucoma, that has its important indication of early follow-up.
Okay. All right. So the next question is, what are the key features in OCT that usually suggest the progression of glaucoma?
Yeah, definitely. Progression we can see in suspect also. So in the suspects, in established glaucoma, of course, the OCT machine, the RNFL OCT machine has itself the software, same guided progression analysis. We can see, we can assess progression on OCT itself. The software is incorporated in the machine itself. So the next time, maybe 6 monthly, few years, 2, 3 years, and then annually you are calling your suspect patients. So the machine will give you the printout of guided progression analysis itself of
Hmm.
regarding this progression. So you can see that RNFL thickness, successive printouts, and the deviation maps, the serial printouts of the patient will give you progression, definitely. So OCT has an important importance in the progression also.
Okay. And this can be seen along with the visual fields as well, so that we can
No,
do.
no, no. In suspect, I'm talking about in suspects.
Okay.
In suspects, in ocular hypertension, in glaucoma suspect, you can follow up your patient for progression
Hmm.
on OCT.
Okay.
But the visual fields are not showing us anything. So the OCT, the color and the red free pictures,
Hmm.
you should record on any every examination and you can compare. Because the visual fields are not giving us anything at this point.
Yeah, right. So that is useful only in already diagnosed patients, where we can actually overlap both.
Pre-perimetric glaucoma, the terminology. Yeah, RNFL OCT has an important
Hmm.
role in pre-perimetric glaucoma and their follow-up also. Yes, of course.
So we prefer OCT RNFL in the follow-up, right?
Yes, yes, yes. In the because they are suspect, they are not showing us any visual field defect.
Right. Okay. And is there any correlation or both this RNFL thickness and the GCC? Do they complement each other, or do we look these things as two different things in progression?
What is GCC? There's the ganglion cell, then axons. Okay, so everything is coming from the optic disc. The ganglion cell are 50% or more are concentrated on the macula.
Right.
Okay, and
Mm.
they have thickness more. There are 5, 6 layers at the
Mm.
macula.
Mm.
So a very focal loss of ganglion cell will trouble the patient more.
Mm.
Okay, so it will give us the patient more defects. The
Mm.
patient will see a worsening of the patient symptoms if
Mm.
there is more, if there is very small loss at the macula. So the machine, what the OCT machine is showing us, the GCC at the macula. So
Okay.
what I was telling you, the RNFL is equally important, the peripapillary RNFL, but the entire retinal nerve fibers are concentrated on the optic nerve. So suppose there is some defect in the periphery, this
Mm.
might will give you a small RNFL defect and maybe a 10%, 15% loss in the periphery, which will come to you in the form of nasal step. Oh, nasal step is there. But a small loss of ganglion cell at the macula will give you a very small paracentral scotoma. But there is a more significant loss there. So that should be picked up.
Okay.
So the nasal step will trouble you more. Oh, there is nasal step. It is going to form arcuate. But the patient is troubling more with that paracentral scotoma. So might be 5% loss, 10% loss in that macular area of ganglion cell will trouble the patient more than the maybe 20-25% loss in the periphery, because that is periphery. So we need to pick up these ganglion cell loss in the macular area early. So the OCT is showing us obviously in the form of ganglion cells, thickness, but 10-2 also has its importance in these patients, because we are not focusing on these patients are not showing any peripheral defect. Suppose the
Mm.
defect is only there is some patient is coming us with paracentral scotoma. So you have to again ask for 10-2 examination. So the paracentral scotoma or the defect in the macular region will give you a magnified view in the visual fields.
All right. Okay. And yeah. So one more question I had regarding like 24-2, we actually prefer while ordering for glaucoma visual
Glaucoma patient. Yeah, sure.
defects. And for like, if it is not possible, we proceed with 10-2. Right. So
Possible, like the patient is not
no,
doing it, or
it is like, yeah, no. If there is like too much of defect in it, we just proceed with 10-2, right?
yeah, it is advanced glaucoma, you're
Yeah.
saying.
In
Okay,
such
yeah.
cases. When do we, ask for 24-2C? Are there any specific indications?
No, so in all the glaucoma patient, we are ordering 20, we are doing 24-2 for all the glaucoma patients. So what is 24-2? Nasally, it is saying 30 degree, not 24 degree. And elsewhere, it is giving, it is testing 24 degree from the point of fixation. Why 30 degree nasally? As you know, the anatomy, what is the initial defects which are supposed to occur in glaucoma patient begins with nasal step, inferior, superior, and there is exception of that Anderson criteria also nasally. So if there is edge points there, 3 or more edge point nasally, they are included in that Anderson criteria. So 24-2, we are asking for all the glaucoma patient. If 24-2 is showing us generalized depression, superior and inferior arcuate. So to redefine, to look more, we ask 10-2 for that patient. Of course, we are doing 10-2 then for more advanced glaucoma. 30-2 nowadays has more value in neurological disorders.
All right. Okay. All right. I think with that, we'll wind up the session and we have come to the end as well. Thank you so much, Dr. Jyoti, for joining us. And it was indeed an amazing class by you. So,
Thank you. Thank you, both of you, to chair this session and make it more, for making it more interesting. Thank you.
Thank you.
Thank you, ma'am. So we meet on the 28th of May for the Grand Viva, Interpretation of Retinal Imaging and Instrumentation by Dr. Ankur Singh. Until then, have a nice weekend. Good night. Thanks a lot.